really think about him. He's a disruptor. He's a person who thinks of new things to do. He writes about them. He nags people about them. He employs power politics at times, I've noticed, to make things happen. And he's just recently started a new department at Harvard. And from what I've heard, starting a new department at Harvard is almost like getting elected president or something to make it happen. So Zach is a real leader in this field that we're talking about. I really look forward to hearing what he has to say.
Thank you very much. So I did not know when I came onto the stage, which, by the way, its frigidity is only exceeded by the warmth of the personal presence here. What I did not realize was that I had one over our previous speaker. And the one is the year of my mother's age, who happens to also have multiple myeloma. And she and I, too, walk around. And she, too, appreciates the nerd factor because although she's extremely appreciative of her physician, she repeats to me often and often, she says, Zach, I appreciate that you have an MD, but it's the PhD part which I think is more important because you know what? The person who really cured me, or made me be able to walk around with you, are the people who discovered the drugs. I'm telling you, unfiltered, that's what she says to me, and she'll stick by it if you ask her. So I do want to say that what I'd like to cover the next 10, 15 minutes is how the MMRF, in my view, creates the model for precision medicine. And I'd like to try to quickly fast forward where that model may lead us. I think you've heard it's going to be a patient-driven model. And at all levels, accumulating the data, directing resources, following up the effects of our cures, and ultimately agitating for the right treatment at the right price is going to have to be a patient-driven effort. No one else is going to do it for us. So here's an aspiration. This would be great if medicine looked like this, although it may look terrible to you. Okay, what do we have here? We have pretty woman, an officer and a gentleman, and an American gigolo. What is this? These are the probability links of you ordering your next film at Netflix based on what you've seen so far. Now, when you go see your doctor, you would hope that your doctor remembered, perhaps it's the same doc, perhaps not, everything about you, all your history, and reloaded that into their brain in that 10-minute session. You'd also hope that they knew everything about all patients, not in their clinic, but in the world, that looked like you, so that they could say with precision, this is the right diagnosis, and therefore this subclass of myeloma is treated by the following drug. Unfortunately, even where we know these things to be true, this is not the case, obviously, in medicine. We're lucky if they remember you. We're lucky if they remember all the patients in the clinic. We're lucky if they remember the medicine, the half of medicine that still is right from medical school 20 years later. And we cannot hope that they know all patients like you. And yet, here's this data play where they rank and score all these movies that you've seen. They know all your history. They know the history of all the movies that everybody else has seen. They've made the data available so that data nerds like myself can compete and figure out what's the best algorithm to predict which movie you're going to like. And this advanced their business, by the way. They have the best algorithms. We have nothing like that in medicine. Why don't we have anything like that in medicine? There are many reasons. And many of the reasons are being addressed directly by the MMRF. And so, actually one more thing. And so, look at their objectives. Maximize consumption and enjoyment. We could actually redo the slide and just say, maximize safety and efficacy. But we have nothing like that. We do not have a data economy or ecosystem that does that. Why is that? A big reason that we have a new department of biomedical informatics at Harvard is because we realize medicine doesn't think this way. They think that somehow we can have accountable care without counting. We can have precision medicine without precise measurements. So, what about precision medicine? What's it going to take to make it happen? I wrote a recent Science magazine article about what are the challenges in precision medicine. And I have this figure to show the 10 things that we have to get done to make precision medicine successful. On the y-axis is how difficult it's going to be. The higher up, the more difficult. On the x-axis, going from the technical to the socio-political. And I just want to quickly go through these 10 things because it addresses many of the challenges that MMRF is meeting. So accuracy. Getting accurate measurements and accurately lining them with patients is expensive and difficult. But if you have a patient-driven movement, it's doable. Linking patients to their data is very tricky because maybe if we can overcome all the problems with electronic health records, we can access the data. But guess what? There's much more to your health than electronic health record data, much more than even your Fitbit, where you go to work out, what your family history is. All those data, which are hard to get, and some are not even indexed by anything that we would think of as a health record number, are relevant to your health care. But guess who has the right and the unique ability to bring all that data together? The patient. Nobody else has the right or the right data to bring together. Omics writ large. Measuring comprehensively data is key. If we had only looked at 1 or 2 genes at a time, we would never have the breakthroughs that you heard Kathy talk about. So we have to measure everything at a time. But guess what? That's only one omic measurement. Turns out, a lot of our diseases, in fact, all the common diseases, are at least 50% influenced by the environment. We're going to have to start measuring the environment in an omic-like fashion. Representation. We have to get a representative cross-section of patients. Because guess what? There's a lot of things that are similar about us, but there's a lot of things that are different. So if you look, for example, at hypertrophic cardiomyopathy, a genetic disease that affects hearts, many of the variants that are right now on the books as causing disease are a disease that's 1 in 500 are present in 20% of African Americans. They have a different structure of the frequency of different genetic variants. And so whether you're Ashkenazi Jewish, European, African, or Asian, having representation for all diseases is going to be key to avoiding severe malpractice. Perpetual updating. The meaning of your genetic variants or clinical findings today are not the same as they were 2 years ago. So it's not just now good enough to say, here's your result. You have to say, here's your result, and in 6 months, as the literature progresses, here's your result updated. This is what it means to you, again and again. And it's only by having the kind of commons that MMRF has, where you both know the new results and you know who the patients are, so you can actually inform them, that you can actually have that virtuous cycle of perpetual updating. Blurred boundaries. I can't tell you how many times I've had to deal with the following fact. In this cutting-edge area of research, clinical care and research are blurred. Problem is, our institutions don't like that blurring because they have a neat way of doing research covered by IRB and a neat way of doing care. But when we start looking at things that medicine barely understands, like genomics, then we actually are blurring those boundaries. And if we don't cross those boundaries And if we let the institutional standard way of doing things keep those apart, we're not allowing science to move forward fast enough. Education. Notice that's the highest level of difficulty. And when I say education, I don't mean patients. I mean doctors. Even back in 2003, an amazing 30% of primary care physicians were ordering a cancer genetic screening test. And the highest predictor of those doctors ordering that test was the patient asking for the test. But here's the problem. The doctors have been shown in multiple studies to be neither competent nor comfortable interpreting these tests. So educating doctors about genomic medicine is going to be key. The vast, vast, vast majority of doctors do not understand this. And it's undertaught in the curriculums, and it's taught at sort of a basic science level, and not how do you do this in practice. I cannot overstate how much of a barrier this is. Affordability. I am so glad, and I would pay whatever remaining dollars I have in my wallet for my mother to get these drugs. But in the end, we can afford them when they represent 1%, $100,000 a year, 1% of, let's say, heart disease. But if they represent 50% of heart disease, then $100,000 a year is no longer affordable. There will not be enough money in our 100% of our GDP to pay for these drugs. So the affordability issue is something that patients, only patients, can vote for, because the market, we don't have a clearly free operating marketplace. And in the absence of that marketplace, we have to make our stand. And that only happens with popular support. And notice it's the further out on the social political, but I don't think it's hard. I think Kathy and others have shown us the way. And getting that popular support for precision medicine, I think, is the most important driver for all of this. So having said that, there are now a multiplicity of data plays to create these information commons. So for example, at Children's Hospital, we were approached by two mothers who have children with something called Phelan-McDermott syndrome, rare disease, less than about 1,000 children. And with funding from the Patient-Centered Outcome Research Institute, with less than $1 million, they put this together. The moms brought together all the genomic data from across hundreds of institutions, patient-reported outcomes, clinical records, and it's all in one database that allows them to put this together. And so I think we're going to see more and more and increasing affordability of the kind of data commons that MMRF has pioneered. And as we wrote in a Nature Biotech article recently, what's going to happen, I believe, is we're going to see a network of networks. We're going to see multiple disease-specific registries. But guess what? Because of what Dr. Califf was talking about, the fact that we have these comorbidities, these diseases overlap one another. So we just heard about myeloma and atrial fibrillation. So you can imagine that there might be an atrial fibrillation network and a myeloma network and a cancer network, and they're going to touch each other. And they have to interoperate, because otherwise we're going to be reinventing the wheel again and again and again. So technically, I can tell you it's not challenging. Politically, it's very, very challenging, because the reflex of don't mine my data is ubiquitous at all levels, at the levels of individual investigators within institutions, companies, and even countries. So enabling that federalist view of data to exist is essential. And I think that the MMRF will end up being a first-class citizen in that federalist system. We talk about data pulling out. What about affecting care? So there's an incredibly successful program called the Undiagnosed Disease Program, which is at the NIH. And it had this rare track record in that patients who are not diagnosed for years were sent there, sequenced and sent to the right doctor. And then an amazing thing happened. Congress assaulted them because they were not seeing enough of their constituents, because everybody wanted to be seen by it. So there was a bipartisan agreement to blow this up to a national program. So the Undiagnosed Disease Network, which we run at Harvard, the coordinating center for across the country, covering 7 big academic health centers, 2 sequencing centers, and 2 validation centers, says the following. A patient applies to the network. All the data from that patient goes into a database that actually is HIPAA compliant, and because it includes also some federal data now, FISMA compliant. It's in the Amazon cloud, which, by the way, is more secure than almost any of our hospital databases, and certainly more secure than the IRS's database. And we've gotten IRB and data sharing agreements from all the participating institutions that you see here. I can't tell you how much blood had to flow for this to happen, but it did happen. And so I can tell you, yesterday we went live. And so what we have is a real national network, coast to coast, 7 big academic health centers. And you have a disease, or your loved one have a disease, and you're failing in your health, and we don't know the disease, you could today go to the website and apply. Your data will be sequenced. Your data will be pushed into the cloud. All your clinical data, it'll be shared throughout the network. And so we'll have the right provider with all your clinical data, with your expertly interpreted genome available. Now, here's the thing. We're doing this for undiagnosed diseases. It's pretty clear to me this is what any patient should want. So I think what we're doing is we're foreshadowing the future here. And it's with the kind of acceleration that the MMRF has shown. We can bring all the data. We can contact the patients, that we can now scale up to the national level. Right now, it's a very generously funded NIH project. But this is precision medicine, where the distinction between clinical care and research, because we don't know what these diseases are of these individuals, clinical care and research completely blurred. And based on the history of the Undiagnosed Disease Program, its predecessor, there's a 60% meaningful diagnosis rate. So this is after we've been seen by the best and brightest. We still don't know what's happened. And after that hard threshold, nonetheless, 60% meaningful diagnosis. So I can say that I'm, like Kathy, extremely optimistic about this. And when I walk with my mother and I see other friends who, unfortunately, who scarily, I can say, would be dead without these new treatments, and when I see what's happening in our academic ecosystem, I'm very confident that more and more people will be saved. And so therefore, I can only say to Kathy, thank you for your leadership. Thank you for doing this. And I'm very sorry I can't stay for the rest of the day, because being a department chair, as he said, requires you to do a lot of talking in various places. So thank you very much.